Welcome to Stethoscope, everyone. This is Hawaii Medical Association's News Hour devoted to taking on issues that are affecting our community from a health standpoint. Today we're going to examine the pre-authorization mania that has struck the community, led by the Hawaii Medical Services Association, or HMSA. Do you remember when a doctor's order was a doctor's order? Well, folks, that's not so much the case these days. We now have a lot of pre-authorizations that, in spite of all the time that your doctor has spent going to school, learning how to diagnose your condition, what test to order, how to treat it, now all of a sudden we've got kind of what I call a mother may I environment where you have to ask for care for different problems and hope you can get a pre-authorization. And we have on our show today a distinguished panel of guests. We have two board-certified radiologists, Dr. Richard Desjardins, board-certified radiologist trained at USC. We have Dr. Stephen Holmes, a board-certified radiologist and imaging specialist trained at Wake Forest. Also joining us is Dr. Christopher Flanders, the Executive Director of the Hawaii Medical Association. In addition, we also have Richard Turbin joining us today. He's not a doctor, he is an attorney. Early accurate diagnosis is the foundation of good medicine and good cost control.
Absolutely.
And that's the fundamental truth. And anybody that says anything else, or what these guys are inferring, that they're trying to protect the patient from us. Yeah, right. I got a real problem with that. I'm sorry. You're going to get my hackles up.
Okay. If I could, let me just tell you about the meeting that I went to with the Hawaii Neurological Association about 5 weeks ago. They requested a meeting with HMSA and NIA to have a roundtable discussion about this pre-authorization because the neurologists were very upset. One of the mainstays of their diagnostic workup is neuroimaging. And the expert from NIA that attended did so by video conference from San Diego. He was 89 years old and had retired from the practice of medicine in 1999. That was their expert at the table. Is there a relationship between the number of denials and the money you're getting paid? And because HMSA has hired this organization, they did not answer that then. They said they would get back to us, and they never responded, okay? And we said, well, maybe the insurance commissioner ought to investigate and find out how much is NIA getting paid and what exactly is the relationship relative to the number of denials.
How about this question, Dr. Holmes? Who is NIA anyway? It's kind of mystery shadow group.
It is. I don't know.
Acronym. What does that stand for?
National Imaging Association.
National Imaging Association. And who are they?
We really don't know. Nobody knows.
That's a little frightening.
It's a little frightening. And what's interesting too is they said that there is no accountability in their denial scheme. They are denying imaging request with the concept that they're going to cut back 30% in use. And they expect some of these denials to be reversed, but the person that makes the denial is not recorded, he does not have a track record, and his denials, when they are overturned, there's no record of that either. Because my point was that if you have 10 denials and then you have nine of these overturned on review, then that reviewer is not competent. But they refuse to provide that data.
But what are the criteria by which they decide whether to allow an MRI or a CT or a heart study to go forth or not?
Guidelines that have been discussed in various medical journals over the years, and they've accumulated these guidelines, and even though they are guidelines, they are actually carved in stone for this organization. They are criteria and not guidelines. Physicians use guidelines as a subjective kind of path. These are criteria, and if you're not in that criteria, you are excluded. So they're not guidelines, they're criteria.
But I understand they're not revealing what they are, so it's all going on behind some kind of closed door or some magic curtain or what?
Actually, the guidelines are written down, but what's interesting, in many of the denials that the neurologist brought to the table that day, they were denied even with the appropriate language. For the denial, it's just a form letter, you were denied. And again, there's no name attached to the denial. So even with the appropriate criteria as published in NIA, they're still being denied.
Dr. Richard Desjardins, you were recently in an article in the Honolulu Advertiser and interviewed regarding your displeasure with this turn, I call it pre-auth mania, that has all of a sudden hit our community through our #1 and largest private health insurance carrier, HMSA, Blue Cross Blue Shield. What do you know about this?
What we learned in our experience, in our practice, in our private radiology practice, is we had a substantial decrease in utilization of CT imaging, which is one of the facilities that I have in my office, by 30%. Within a 2-month period, 30% drop in the volume of cases that we were doing. Substantial decrease. The physicians that referred to us when we discussed it with them told us that they could not get authorization. Dr. Scott Grosskreutz, who was at the meeting with Dr. Flanders and I with HMSA, indicated to us that they did a study there where they followed 8 cases that were MRI requests, that MRI had been requested of the approval process through HMSA, and all 8 were denied. But when you use the ACR select criteria, every one of them scored a 9 out of 9 on the selection list, which means that they were perfect cases for use of MRI examination. But
ACR stands, what's an acronym?
American College of Radiology.
Okay, and that is a professional group.
That is a professional group of radiology.
Practice radiology.
Right, and ACR has created a evidence-based program and selection of guidelines, and using those guidelines, they have created the ACR Select program, which is a program that is designed for pre-authorization of a type that has helped physicians to select the appropriate examinations to choose for their patients. It's not meant to be a denial system. It's meant to be a system of guidance. It's not cutting people out of the program. And 9 points is the maximum that you can score on this scale, 1 to 9. If you're scoring from 1 to 3, you're probably inappropriately requesting that examination. 4, 5, and 6, you're kind of in the gray zone area. The higher 7, 8, and 9, those are appropriate patients. Every one of his cases were denied, although they all fell.
Clear-cut cases where, based on real professional doctors that actually practice radiology, agree that an MRI should be performed in this situation, but they were denied by this NIA group on the mainland that no one knows much about. Is that correct?
That is correct.
So to me, that's unconscionable.
And one of the requests that the neurologist had as a group to this organization, they said, instead of you denying these prospectively, especially since you're not trained neurologists and some of your physicians are well beyond retirement age, how about we do a retrospective analysis? Give us the gold cards and let us order what we want. We'll do a retrospective analysis, and if we have any outliers in our society, then we will educate them. The point being is that these are doctors that have been to 14 years of medical school and training. They know their patient. They know what they think their patient needs in terms of imaging, yet it's denied by this third party that knows nothing.
In some cases, the one case that I am particularly familiar with, a physician was asking for a MRI exam on a neck of a patient with neck pain and appropriate symptoms, and he was told that he would have to have 6 weeks of physical therapy before they could, without improvement, before they could reconsider the authorization for MRI exam. And to go through physical therapy without knowing what you're dealing with and what you might be causing in the way of damages.
What if it's a tumor? How would physical therapy help that?
It won't help that. What if it's a bone spur? What if it's a compression injury? What if it's a fracture?
What about a blood vessel that could be about ready to burst, like an aneurysm or something?
Patients
Yeah.
Recently at our center came in with abdominal pain. They came from urgent care clinics. Abdominal pain for a CT. The CTs were denied. We could have done it within 20 minutes. Because they were denied, they were sent to Queens Emergency Room. Both patients ended up in the emergency room for over 6 hours. Their CT scans were negative, but the additional cost of having to go to Queens Emergency Room was unbelievable and very inconveniencing for the patient. And I have seen 2 patients thus far that had brain tumors that the diagnosis was delayed because of this denial process.
How much more did that cost ultimately the employers that pay the premiums in our state? How much more did it cost to make a patient have to go through the emergency room to get a study that a office-based doctor or an urgent care doctor could have?
Thousands of dollars, easy.
Per visit.
Yes. And the other option of getting an exam done without the pre-authorization is to have a patient admitted. Once they're admitted to the hospital and they're an inpatient, then they don't need pre-authorization. But again, thousands of dollars, like Dr. Holmes says, thousands of dollars spent on doing what we could do on an outpatient basis, faster, cheaper, easier. They're not saving money, and they're certainly not saving the patients any distress.
And, you know, one of the things they keep bringing up without documentation is that physicians in Hawaii overutilize imaging. That is blatantly not true. And when pressed to provide that data, they can't do it. They won't do it. So they can say what they want to, and they are not held to any standard whatsoever.
I have here the tracking record from, I believe this is, Dr. Flanders, why don't you address this? I'll hold it up while you're talking.
This is data that comes from CMS, and it's Medicare Part B data, and imaging spend per 1,000 beneficiaries. If we were looking at the chart, the top dark line is the national average per year is along the x-axis. The lighter blue line that's toward the bottom is Hawaii. And see, there's about a 35% difference between the national average and Hawaii. Hawaii spends 35% less than the national average. So when they talk about overutilization of studies and needing to do this pre-authorization so that they can ferret out where the overutilization is, if the data doesn't back that up.
Looks to me like we're underutilizing here, not overutilizing, based on this.
It makes me concerned we're not doing enough studies.
When you compare our numbers to the national listing of all the states and from the same data, we are number 44 out of 51. We are near the bottom of the states in terms of the amount of utilization of examinations. We are not at the top. We're at the bottom.
So how does this work? The Hawaii population is paying HMSA premiums. HMSA is paying NIA to deny imaging and medical care to Hawaii patients. That doesn't seem right, does it?
No, it does not. And without having seen our patients, without knowing our patients, without knowing their history, without knowing their physical exams, without knowing anything about them, they deny.
And they're doing it to save money, period. And then HMSA can easily disclaim, this is NIA, this is not us. Well, that's Shabai. They have hired NIA.
Yet they are paying someone to deny healthcare in Hawaii.
Exactly.
All right, I got two board-certified radiologists sitting with me here at the table. What's all the hoopla about MRI and high-resolution CT? Why is this important to medicine and healthcare and doctors doing what they do? Dr. Disney.
It is absolutely critical for us to be able to see what we need to know, what the anatomy, the physiology, the pathology that we find inside the body that you aren't going to see, the physicians aren't going to be able to detect in their physical exams. We're the eyes of the examining physicians. We give them the insight, what we can see inside the body. It's a tremendous window into the anatomy, and it has moved forward tremendously over the years. That's why the utilization of those imaging systems has gone up, because we give them good information. We give them solid, standard data that they can use for their treatment, and it's nothing but beneficial.
Dr. Holmes, why this high-tech imaging?
Well, what it does, it gives, like Richard said, it gives you the answer. Instead of costing or increasing healthcare costs, it diminishes healthcare costs because it provides the exact information needed for that next step. So there's a big fallacy here that is in play, that NIA says we want to protect the population from radiation. That's disingenuous. We have low-dose CT scanners now. CT scanners are used judiciously. It stops the workup, or it directs it the appropriate direction, period.
One of the things that we kind of have to remember to remind these people is that MRI examinations have zero radiation at all. They're good technology, good imaging.
No risk.
No risk, no risk.
So this is getting in the way of a fundamental premise upon which doctors operate in reaching a diagnosis and helping people with their problems. Is that correct?
Absolutely.
All right.
Exactly.
Thank you, John.
Or ruling it out. There's a lot of comfort in having a normal imaging study. The patient, if you're the patient, you are put at ease immediately. It's just as therapeutic to have a normal study as it is for the doctor to find something abnormal to work on. I guarantee you.
You're here. Thank you very much. We're to keep fighting the good fight. Hey, you know what? We're not fighting for us here. We're fighting for our patients.
Well,
I can't stand making somebody wait for a diagnosis that doesn't have to, and that shouldn't.
These days.
To the legislation, it talks about delay, the undue delays. And the point that I was trying to make to them is, when it's your health care, when it's your mother, your father, your children, any delay in their health care is undue, any delay. And they say, oh, well, 24 hours, 48 hours, that's not so bad, is it? Well, it is if it's your stroke, if it's your family member.
Well, sure. And Dr. Desjardins, if we were talking about a 24-hour hold or 48, that would be one thing. But what I understand from these NIA guidelines is that they're insisting that somebody go get some lengthy physical therapy to see if this pain or problem will go away. Which could be disastrous in certain diagnoses with respect to blood vessels that are about ready to pop, an aneurysm that's about ready to go, a tumor that's rapidly growing. But we're fortunate enough to have Rich Turbin here today with us, and I wanted to ask him his take from a legal standpoint on the implications of delaying a diagnosis or anything that hinders a doctor from reaching the medical truth of what's wrong with a person.
Right. Well, first of all, right off the bat, it's immoral. I mean, because you're injuring people, and we all know the oath that doctors take, that you shall not injure a patient, and these insurance companies, medical insurance companies, are injuring patients, and so it's immoral. First of all, it's illegal. Secondly, we'll get into that in a minute, but what do you expect when we have a society that's commoditizing healthcare, which our society does, the only society in a developed country that does it? Why in good God's name do you want to have insurance companies being responsible for our health care that are profit-making institutions? I mean, mega-billion-dollar institutions, and what's the statistics? 30% of our healthcare dollar goes for administrative costs for insurance companies. And really, when we talk about administrative costs, we're talking about profits. I mean, because how many HMSA executives make over $1 million a year? I think 10 or so. I mean, why does our society have to pay for that? Why should our society pay for that? It really is immoral. So we have to take a look at the moral questions, I think, and ultimately it's a political issue too, because the big multi-billion-dollar guys, they're running our economy, running our country. So at some point we're going to have to face. I'm
with you all the way, and it's a horrible situation. But if I'm listening to your advice to doctors that are listening to this show, and that's a big part of our target group with this stethoscope, this news hour we have, what advice do you have to doctors then that are experiencing this kind of foot dragging and delay in an ability to help the patient? Document, and show a real effort at trying to overcome this resistance that we're getting from HMSA and NIA group. Is that one of the best things that we can do? Well, I mean, it's what you're bound to do. For the
Well,
patient,
to protect yourself in an individual case, you know, you're going to have to, you know, paper your medical records and say, you know, I believe that I believe that an image is necessary. I have done everything possible to appeal, you know, to the insurance company. I've told my client what the problem is and proposed that my client, you know, go into his own personal savings and, you know, and pay for one. So you want to do everything, you know, possible to show that you did your utmost to try to get the patient the image. Now, I mean, places an impossible, I mean, a close, almost impossible burden on the poor doctor. I mean, that is really awful. But I think you've got to do what you're doing politically, and I commend you so much. It's courageous. I mean, going to the legislature and fighting with the legislature to stop this business right now.
You know what a lot of doctors are saying to their patients, just go to the ER. Just go to the ER. Because if they can't get the study they need, go to the ER.
Yeah. You know, call the TV cameras. You know, get the lawyers to help you. We got to educate the public that these guys are bullies. They don't care. They don't care about quality medical service. You know what they care about, the money.
The implication here is that we are in a conflict of interest of some type, as I'm reading the communique from HMSA's medical director, that they're trying to protect the patient from us, or some kind of pretzel logic
that's BS. I mean, we all know that that's BS, but we have to educate. Got to make it news. You know, you got to really make it news, so there's constant education to the public that these guys are being incredibly greedy.
And I think we also need, of course, case histories. Those doctors that are watching this show, any patients you have that are having difficulty, a real difficult time getting the diagnostic test they need, we'd like to have names. You can call Hawaii Medical Association with those. You can go on our website with those as well. And I'm sure that maybe the Bar Association would enjoy, as this past
class action. We might
a little bit about bad faith. What is a bad faith suit? I understand that's one of the few things that gets insurance companies' attention these days.
Okay. We forget insurance companies are a utility. We forget that with our electric company too. But insurance companies are utilities. They exist to make society better. I mean, that was the whole point of developing insurance companies, where it really developed in, the ancient Venetian Republic, and they were regulated by the state because they were necessary to have society functioning well. It's a utility. It's like water. It's like electricity. And they have guaranteed profit.
And HMSA
they have a guaranteed profit.
It started here back in the 30s, 40s. HMSA started here with that concept, and it was started by doctors and run by doctors, and the committees that oversaw care guidelines and things had real practicing doctors, but some went wrong somewhere here. Something has gone wrong.
The point is, people don't realize that insurance companies are public utilities. They are enabled to have guaranteed profits, right? Because they can have their premiums raised, so they're guaranteed a profit. Wouldn't it be nice if I was guaranteed a profit? If you were guaranteed a profit? It's one of the few operations that's guaranteed a profit. And so therefore, I mean, our courts have said that insurance companies have a fiduciary duty. You know what a fiduciary duty is. A doctor has a fiduciary duty to his patient to provide good medical care. A lawyer has a fiduciary duty to his client to provide good legal care. If we don't do that, we lose our licenses. That's a breach of fiduciary duty, and that's what should happen to insurance companies. But the law, the Hawaii Supreme Court has enacted, at least 3 separate cases. The most famous case is called the Best Place versus Premier Insurance. And that has said that an insurance company must not commit bad faith towards its insured. It has a fiduciary responsibility to its insured. It's a relationship like a doctor and a patient, or a lawyer and a client. And so they have to operate in good faith in their best interests.
A lot of people aren't feeling the love these days, that's for sure. Go ahead.
Are they not supposed to be acting as an intermediary between the paying organization, between the doctor and the patient? They're the intermediary that conveys the funds between them, or at least part of the funds. So where did they get the right to become a controller of the health care delivered? They're taking the role of the physician. They're saying, oh, we're going to tell you what health care you can have, how you can have it, what you can get, what you can't get. That seems to be an inappropriate use of their function.
I call it Mother May I medicine. Let's talk about House Bill 2740. Now, this is going through right now. It was written to help protect patients from delays in diagnosis and delays in treatment, and holding insurance companies accountable for those delays when they injure a patient. Good, bad, what do you think? Dr. Flannery.
Yeah, so the HMA is, we've gotten involved with this case pretty deeply, and you know, we like the idea that we need to put the brakes on HMSA and their prior authorization scrutinies. The physicians are hurting. You know, in Hawaii we work at a marginal premium anyway, and for any kind of decrease like this in our access to medical care and medical technology, and our patients' access to medical care and medical technology, that really kind of tightens the door for us as far as sustainability of practices go. So our feeling is that it's in the state's best interest, it's in public policy's best interest that we do away with this prior authorization scrutiny.
We only trained for how many decades of our lives to make that decision about what technology should be brought to bear for what particular problem. And then what follows is the treatment, of course. And this is my bottom line issue. Nothing should ever get in the way of a doctor's ability to make an early, accurate diagnosis of a condition. Because not only is that the foundation of good medical care, but also of good cost control. And that's a real bottom line. I think there's room to discuss, debate even on the treatment side, but nothing should get in the way of an ability of a doctor to find out what's wrong with a person. The public depends on us to do that, and we will do that, and Hawaii Medical Association is committed to that. If you're watching this show and you're a doctor, join Hawaii Medical Association, because we're down here fighting the good fight on behalf of the patients and our profession. So thank you all for joining us. I want to thank our distinguished panelists here today, and we'll see you next time. Aloha.